would you describe your urine if you had to put some terms or adjectives there? You might use the terms amber, light yellow. We might use the terms straw-colored or straw yellow. We know that sometimes, depending on how much fluid we take in, it can be a darker yellow or a very light, almost clear color. We know, too, that certain foods will give urine a different color. If you eat beets, perhaps, you find that your urine looks red. It looks beet red. And then certain drugs will cause the urine to change color as well. We know that the urine should be clear and not cloudy. And as you look at urine specimens, sometimes you will notice that there might be sediment down in the bottom of the cup. This should be noted and, of course, reported. Urine also gets cloudy as it stands or as it sits in specimen containers or in catheter bags. How do we describe the odor of urine? I'm sure you've all been wondering about that one, right? Okay. Well, we find that we describe urine by ammonia odor. Many times we use the term characteristic odor. And sometimes you find that food also will change the odor of urine. Diabetics might have urine that has sort of a sweet smell to it. It smells almost fruity, like you have some fruit. We know that the amount of urine that one passes is usually about 1 cupful. It's usually equal to about 1 coffee cup or 1 container of a milk carton, about 250 cc size. Now, we know that as the bladder fills up with this urine, when it gets to be about 250 cc's in size, and again, picture the size of a coffee cup, that stretching activates nerves in the vessel in the bladder wall, which in turn activate nerves in our brain, sending impulses down so that we can evacuate or empty that urine. You have the urge to urinate, and you take yourself to the bathroom. So that stretching and that filling of the bladder becomes important to activate those reflexes that make us go to the bathroom. What about urination? Well, when we talk about urination, we talk about the act of passing our liquid waste or urine. This is also called voiding. And when we say somebody has voided, we could also say they have urinated. Usually we put out about 1.5 quarts in a day. Now that looks like quite a bit, but basically if you think about it, you've taken in probably 2 to 3 quarts. And remember, some of the other fluids have been put out through your skin and through your lungs as well as through your bowel. However, there are some things that can cause an increase in urination. Such things as diuretics or water pills are often given to patients who have excess fluid in their system. And these people will go to the bathroom frequently and usually in pretty large amounts. Remember that if they have to go to the bathroom and they're on a water pill, they have to go. You cannot wait. You have to get to them right away. We know, too, that salt tends to hold fluids in the body. And if you have a meal, for instance, perhaps of a ham or some foods that is very high in sodium, you might find yourself feeling somewhat puffy or bloated because of that. Now, what about frequent urination? We know that we normally urinate probably, every 2 to 3 hours. Others might go 10 or longer, 10 hours or longer. Not usually do we urinate during our sleep. If the person does urinate during the sleep involuntarily, such as a child might, we call this nocturia, which means they're urinating at night. We know that frequency of urination is a clue that we want to report. If the person is frequently voiding small amounts of urine, say every 20 minutes or half an hour, that might be a sign of a urinary tract infection. If they're voiding, on the other hand, frequently in large amounts of fluids, and I mean quite a few hundred cc's perhaps, 100 to perhaps 300 cc's every half an hour or an hour, that person might be having a problem that signifies they should be checked for sugar content in their blood or diabetes. So frequency of urination is an important clue for you to watch and report it if it looks different. Again, use your own body as a judge. Urination should be painless. There should not be pain as one urinates, either the male or the female. However, there are certain items or deposits that sometimes build up in the kidneys, and we call these calculi or stones. and can be extremely painful when they are passed, not just down through the ureters, but out through the urethra as well. For this particular problem, you might find yourself having to strain the person's urine. And you see in this picture a particular device called a urine strainer, which would be put into the graduate, and urine would be poured through that. If indeed any results were found on the mesh, you would save that, and that would be sent to the lab. We also know that urine is under control. And we learned, of course, as a child, we've learned to recognize the urge to void. Keep in mind that when the brain has been damaged, perhaps due to trauma or disease or injury, or the muscles have become weakened, that urine might escape. And it's not uncommon at this point to notice that a person has an involuntary loss of urine. We also know that people, perhaps that have the ability to feel or sense that reflex, perhaps have lost the ability to use their legs to get themselves to that bathroom. In this case, they can feel the urge, but they need to have you or somebody help them to take care of that. When we look at urine, perhaps it would be easy to look at some things that are not supposed to be in urine, as well as with urination. First of all, I mentioned, remember, there should be no pain. It should be painless. There should be no loss of control. It should continually be under control of the person. And if you do have the problem, or if you know somebody who has this problem, it should be looked at and very likely could be corrected. We do not normally just automatically become incontinent as we grow older. That is not a normal sign of growing older. Older people do not have to have this problem. It can be pretty much evaluated and remedied by and large. There should be no blood in the urine. However, if your patient is still menstruating, there might well be blood during the time of her period. However, infections or injury to the urethra or to the bladder or to the kidneys can, of course, cause blood in the urine. So should you see this, you want to report it. We know that there should be no pus or bacteria in the urine. We know that the urine is sterile. And because of this, we're constantly being cautious to not cause infection by the way we wipe, making sure that undergarments are clean, making sure that the person drinks adequate fluids to flush out the system, so to speak. And then we also know that there should be no sugar in the urine. We know that the person who is a diabetic often has excess sugar that is removed from the bloodstream, and it is taken out through the kidneys. So we know that there are some things that you want to observe for when it comes to urine, when it comes to urination. And keep in mind again that this is all part of your duty as a nursing assistant. One of the things that you as a nursing assistant will be responsible for is to helping somebody who is unable to urinate. Now, one of the problems that we find occasionally with patients is that they retain the urine in their bladder. And when they do this, it can become very uncomfortable. And have you ever had to have a bladder that was very full? You probably found yourself having some real cramps, probably feeling that you were in pain. And then you probably got to a point where you couldn't go at all because you had held it too long. That is a situation called retention. And it can be very painful as well as uncomfortable. We know that privacy is important, and if your patient is embarrassed of making sounds and noises that we would all recognize as passing urine, they may just hold that urine. They may not sit and empty their bladder. However, what we know is that privacy is important, so you will close the doors. Sometimes we even turn the water on. The sound of water will help them to think water. Remember I said we talk about this. Some of you might have just had the urge to urinate just by talking about it. But we also know that for some people, water drowns out the sounds that otherwise they would find embarrassing. Some people find that by putting their hands in a basin of warm water, that helps them to urinate. Also, sometimes we know that if they have diversion, such as television perhaps, or radio, or a magazine, that helps to get their mind off of what's bothering them, so to speak. We know that as we grow older, the urinary system will change. We know that the bladder has less holding capacity. Now, I was just talking about retention, where we tend to hold the urine too long. Now I'm going to talk about the opposite problem, where they're unable to hold the urine as long as it should be. As we grow older, the older person's bladder has less ability or less stretch space, so to speak, before that person feels the urge to urinate. In other words, they may have approximately 100 cc's or 150 in their bladder, and that is a strong urge to urinate for them. And you need to answer that. You cannot wait for them or have them wait for you while you do something else. Remember, that person who has to urinate has that urge right then and there. You can't wait for that. We know, too, that when the older person feels that urge to urinate, they have to urinate when they feel the urge. Now, perhaps you and I, we're younger, we feel the urge to urinate at about 250 cc's, and so we're just not near a bathroom and we just hold it. Well, then it becomes 300 or maybe 350. Maybe when it gets to be 350 or 400, the urge is stronger. Until finally, I think we all recognize there comes a point of no return. No matter what you're doing, you go and find yourself a bathroom. But the older person doesn't have that ability usually to wait and to delay and to put things off until they can find a bathroom. Consequently, if they have that urge, they have to go right now. And I think you need to understand that. That's something that's just part of being the older person. Now, we also know that when we talk about urine and we talk about taking care of this part of our body, we also have to look at the problems of infection. We have to look at the problems I mentioned earlier of incontinence. I mentioned stones. These are problems. I talked about retention. And I think you need to realize that there are many problems that can occur in this particular system. And it would be up to you, of course, to continually observe, to continually report those things that you see as abnormal. And again, I would caution you that as you look ahead to doing this skill in the clinical area, that you will use your own body as a guide for what is normal. Use your own self for how would you feel if you were in the patient's place. Do you want the doors left open? Do you want that person to leave you on the bedpan or the commode for long periods of time while you wonder what's going on? I don't think you would. So I ask you then, as you help your patients with this particular function, to consider what would be right for you, and I know you will do the right thing for your patient as well. The topic of this session will be that of bowel elimination. Now, you might recall from previous tapes that the bowel is a part of the gastrointestinal system, and particularly the intestinal portion. And you've learned in the past that we have two main divisions of this. We have the small intestine, and we have the large intestine, or the colon. The small intestine has about 20 to 23 feet of tube-like muscular material where food really is pretty much in liquid form. Here is where you remember food is digested and nutrients are absorbed into the bloodstream. The large intestine, or colon, is approximately 4.5 feet long. And you will see in this diagram that it is a particular, what shall we say, snake or curve-like structure, which has a very different design on the right than the left side. We know in the large intestine that water is absorbed into the body. Solid wastes are excreted from the body through the rectum or the anal sphincter. And you can see on this diagram, very similar to the one that you have in your materials, that the right side is the side where you're very apt to find, if it hasn't been removed, the appendix. What is passed through this colon and small intestine is called feces or stool. Many people call this bowel movement, or BM for short. Now, as we continue talking about this part of the anatomy, there are some terms that you should be familiar with. And one of these terms is that of peristalsis. Peristalsis is that muscular wave-like motion that propels the feces or the stool, whether it's liquid or solid, makes no difference, throughout this tube structure. We know that as this material is passed through the rectum, it of course is exiting the body. And at that point, it's usually solid or formed, and we describe it as formed by shape. When we talk about defecation, a few things that I think we need to talk about in addition to the terms and how a person might view this particular bodily function. We learn to control this function as a child. We go through toilet training at approximately, 2 years or so, and we learn that we must control those sphincter muscles or circular muscles, very much like an O or a circle, that are around the opening or the anus. We know that the urge to defecate is what makes us go into the bathroom, to sit down on the toilet, to empty that rectal area. We know that it's strongest, or the urge to defecate, approximately a half an hour after a meal. And you might want to take advantage of that if you are helping somebody with a bowel or bladder training program where you have to try to guess when do you need to take them to the bathroom. When we talk about bowel elimination, I'd like to talk about some factors that influence how we eliminate this particular system. The factors are probably common sense, and most of you, I'm sure, know these. But let's review them just to make sure that you have them in your memory. Diet is probably the most common factor when it comes to influencing or affecting bowel movement. We know that adequate bulk is necessary in the form of grains, in the form of roughage, such as you might get in, say, raw vegetables or fruits. We know also that when we talk about defecation and diet, we also must have sometimes foods that are more stimulating than others. I'm sure we've all heard jokes about prunes and what they can do. Fruits, by and large, have a natural laxative effect, and you know that we should take 3 to 4 fruit servings a day. This should give that person adequate amount of roughage as well as natural stimulant. When we talk about diets also, we know that warm liquids such as coffee or tea, sometimes just a large glass of warm water, will actually help to stimulate that defecation reflex. Fluid must be taken in approximately 2 to 3 quart amounts every day in order to have adequate fluid balance in the body. And of course, when we talk about adequate fluid balance, you can usually tell by what the stool looks like. If it's too dry, you probably need more fluids. If the stool is too loose or liquid, you are probably losing a lot of liquid and also should replace that liquid as well. So what comes out can give you a clue as to how much should go in. When we talk about defecation, another factor is that of muscle tone. Now, muscle tone refers to the actual tone of the intestinal muscle as well as the muscles around the abdomen. Peristalsis is a muscular wave-like action of the colon. Exercise is very important for good bowel function. And remember, many of the elderly do not have as much exercise as they perhaps did when they were younger. And it is up to you to try to encourage them to be as active as you can. We know that various psychological factors also will influence bowel movement. Anxiety or anger tend to increase peristalsis. Many times you might find that if you're very anxious or upset, you might find yourself with diarrhea. Depression, on the other hand, slows down that bowel activity, and the person is very likely to have constipation as a result. We know that lifestyle that one leads is a very important factor. Many times people are just too much on the run, and they simply don't take time to get themselves into the bathroom, to take time for that important function. We also know that sometimes bathroom facilities are just not available, or perhaps you just simply, if you have to share a bathroom, such as a patient who shares a semi-private room, you just find that, well, you don't want to share the noise and the odors with somebody who's also perhaps a stranger in your room, your patient on the other side of the curtain. We also know that people develop habits early in childhood, and these become very important throughout life. We have learned, many of us, that the need for privacy is very important. And for somebody who now has to use a bedpan sitting on a bed when, let's face it, when they were a child, they were told you can't mess the bed, you can't wet the bed. And now we as nurses say, here's a bedpan and now you may use it. Sometimes those are very bad habits, you know, that we say we can't do. It's a bad habit to wet or mess in the bed, and we shouldn't do it. This may keep that person from actually defecating. We know too, and as nurses, we many times are giving medications that will have an influence on one's bowel movement. Some of the medications have side effects which cause diarrhea or constipation. But on the other hand, we have laxatives which a person can take to stimulate bowel movement, in turn, of course, causing that bowel to empty greater than it would with a normal bowel movement. We also know that for some patients the stool must be softened, and we have what are called stool softeners, which will allow that person to have a softer, non-constipated stool. And perhaps you've had diarrhea. Let's say you've had a real wild night the night before and you ate all those foods which you know you shouldn't eat. You know, you hear people talk about all the beer and the bratwurst and all those good spicy foods which maybe you have to pay for later on, and find yourself with diarrhea. And you might find that somebody in that instance will have to take some medicine to stop the diarrhea. Those are some factors, and several of the other factors let's take a look at as well. We have pain to consider. If somebody is experiencing pain from perhaps hemorrhoids, we might find that they're going to probably hold that stool and not pass it through their anal sphincter. Hemorrhoids are nothing more than varicose veins of the rectum. And if you've ever seen legs that have varicose veins, you know that the veins become very much like pouches. Well, they can be very easily irritated, they can be somewhat painful, and certainly they can also bleed. And we know that pain sometimes, if we know we're going to experience pain, we try to prevent ourselves from that, and that person is apt to hold back on their defecation. We know, too, that nerve damage, such as spinal cord damage or head injury, brain injury, will not allow us to use the muscle control that our brain has a great influence on. Control may be adequate also, but if that person is paralyzed from the waist down and unable to get to the toilet, they are going to have a difficult time making those bowel movements happen. And then, of course, we've talked in the past about age being an influence. We know that age slows down the muscular activities in the intestine. It causes many problems for the older person. And you will find that many times the older person who has perhaps very little else to think about will think about their bodily functions, will concentrate on those aspects of their daily life that become so important to them. They're not that important perhaps to us, but to that older person who's experienced them, they are very important. And then I think one of the final factors that you need to consider is the fact that we have to be in an upright position to effectively empty the bowel. Now, you'll find that we've looked at commodes, we've looked at how to position people on the toilet with all types of adapters that will help them to be comfortable. And every effort is made nowadays to get a person to the commode or the toilet. The bedpan is the choice of last, it's the last choice we all want. Well, what are some observations that we should make about stool? By the way, isn't this a very exciting topic? I'm sure you're all just out there taking notes madly, so good luck. We're just getting into this now. I remember being a student and going through this too, so I do understand what you're going through. Some of the observations that we need to make about normal stool or defecation. Well, one of the things that you're most commonly going to notice is the color. The color should be brown or dark brown. It's the bile from the gallbladder that really gives stool that brownish color. The consistency we describe as soft or formed. In other words, it should hold its shape. We know, too, that odor is often described as aromatic or characteristic. And then the frequency will vary from individual to individual. We know that some people go once or 2 or 3 times a day, and others will probably go 1 time in 3 days. Everybody has their own pattern, and I think one of the things you must be very aware of, that you do not have to have a bowel movement every day. And many of your elders will tell you if they don't go every day, they're going to feel constipated and they want you to have the enemas and the suppositories, and that may not be necessary. If their normal pattern has been every other day, that's going to be fine for them when they get to be older and in the nursing home as well. In terms of amount, we normally describe the amount as small, medium, or large amount. And I think you probably have to use your own, your own experience with your own body to estimate what is small, medium, and large. And certainly your instructor will help you as well when you're in the clinical area. Let me just mention a couple abnormal things that you should not see when you look at the stool. And if you do, save it and take it to that nurse for her to look at. I find it very, what should I say, upsetting as a nurse when a nursing assistant would very dutifully come running up to me and she'd say, I saw this most unusual stool and it had this, this, and this in it, and oh my, I've never seen anything like that. And I'll go to look at, oh no, I put it down the toilet or I washed it down the hopper. That's a little late. Save it. If it's very unusual, save it so somebody else can take a look at it. Perhaps a specimen would be taken from that. Well, a couple things that are abnormal you should be aware of. One thing is clay color or a grayish color to the stool. That's telling you that there is not adequate bile to give it that brown color. If the stool is black and tarry, we know that perhaps that is a result of digested blood higher up in the intestinal tract, closer to the stomach. We know that if in the stool you see specks of blood, bright red blood, or if you see blood in pools or enough that you could measure, this indicates that there is bleeding lower in the gastrointestinal tract. That could be a result of hemorrhoids being irritated, or it could be another sign, and one should very quickly have the cause ascertained by the physician. I might mention that while we're talking about red colors in the stool, that sometimes beets will give stool a sort of a wine-colored red. It's slightly different than a blood-colored red. And while we're talking of unusual colors to stool, we also might mention that if the stool is black and formed, now remember I said black and tarry stool indicates bleeding. Black stool that is formed usually indicates that the person is taking some kind of medication giving it that color. And iron is very commonly a cause of black stool. Some other unusual things that you might find in that feces or stool. We know that excess mucus is not normal and should be investigated. We know that sometimes there are worms and parasites. Yes, worms and parasites. And they do look like worms too, I might add. These should be saved, of course, and usually a specimen is obtained when you see those. We know too that sometimes pus can be found in the stool. And you will see this, it will be very obvious. Stool itself is made up of about 75% of water. Remember that we reabsorb a good deal of this in the large intestine. However, what comes out of the body still contains a good deal of water, but what the body can afford to give up. Now, what is left after we take out the water from that stool? What is left is pretty much made up of two ingredients. One is, of course, the undigested food that we've taken in that the body does not need or require. And the other part of that stool, a great portion of it, is made up of dead bacteria. This is one of the reasons it is absolutely a must that you wash your hands after toileting, not just yourself, but also helping your patients with this function as well. Dead bacteria might be dead bacteria, but they are definitely deadly to you and to your patients in terms of infection. Now, I have to mention this because I think sometimes we do find, especially with children, that children eat things. They put everything in their mouth. If you've ever had children or been around children, you know that they have great needs to put everything right into their mouth and chew it and swallow it. Makes no difference if it looks good or tastes good. Children like to swallow things, and sometimes some adults will also. The confused person may or may not understand what it is they're swallowing. It is not uncommon, if this is the case, to have to look for it a day or two later in the bedpan. Now, one more thing that we need to talk about is what's called diversion of the stool. And occasionally, due to illness or disease, the part of the bowel has to be removed, and part of that colon, and it can be the small intestine or the large, is brought to the outside of the abdominal wall. Let's take a look at a model that has a diagram of an ostomy on it. You will see here that this mannequin or model has several different types of ostomies on it. And you'll notice that most people would not have four, I might add. This is just a model. but you'll notice that they come in various shapes and sizes, and that in order to help the stool collect, there would be a bag attached around the stoma, and this bag would in turn collect the stool. Now this bag would be taken off, it could be emptied, cleaned out, and in turn put back on. And I may not get it on because that takes 2 hands to do it. But you can see perhaps that this is another way of diverting the stool from outside of the, or to the outside of the body, I should say. The term ostomy really refers to artificial opening, and what you saw was an artificial opening of the bowel. If it's the colon that is brought to the outside of the abdomen, we would call that a colostomy. Ostomy made from the colon. If it's a small intestine that is brought to the outside of the abdominal wall, we might call that an ileostomy. One of the other terms for the small intestine is ileum. So an ostomy with the ileum is an ileostomy. You might want to know that the stool may be liquid in some of these, or it may be solid. And some people will wear that bag all of the time, and others, depending on where the colostomy is, may not even need to wear a bag at all. You also need to know that colostomies can be temporary or permanent, depending on the illness or the original cause for it. We need to take a minute and consider some of the problems that a person might have with bowel elimination. And since, let's face it, this is a human function and everybody does it, please relate some of this to your own experience in your own body as well. I'm sure you're already doing that. Constipation is one that probably you're going to hear tremendous things about from your elderly residents. As I said, they have sometimes very little else to think about except their bodily functions. Constipation refers to the passage of dry, hard stool. And I might add the word difficult passage, because many times a person has to strain or bear down and perhaps be very uncomfortable as this is trying to come out of the body. Constipation is not the failure to have a bowel movement every day. The person may have a bowel movement every day 2 or 3 times a day, and it still might be constipated stool. The causes are many. We could have medications as causes. We could have, of course, lack of exercise or activity. We could have lack of fluids as a cause of constipation. Perhaps the person's diet is lacking in bulk and roughage. If they're on a pureed diet, where they have nothing but foods that have been ground up and soft in texture, they're not getting that type of bulk. What you probably will end up doing is encouraging fluids, increasing the dietary roughage, such as using whole grain foods instead of white bread or toast. Perhaps increasing their fruit intake as well. And maybe for a snack they get a glass of the good old standby prune juice, just to be sure. One thing that you might try too for the person who is constipated is offer them that glass of warm water. They need the extra fluids by and large, and just giving them warm water might help. Now, of course, you make sure that they can have that extra water, to be sure. Most patients will welcome that. One problem that can result, though, if we don't take care of constipation is the problem called impaction. Now, impaction is even less pleasant to talk about than constipation, but let's give it a try. Impaction arises when the stool is allowed to stay in that colon. And it happens, unfortunately, all too often, and then we have to do the things called enemas, suppositories, and really go at this aggressively. But hopefully we prevent this by making sure that the person does have that bowel movement routinely and regularly. One sign of impaction is that the person has not had a bowel movement for at least 3 days. This is so, what should I say, common with our older person to sometimes not have a bowel movement every day. And then some of this is your problem and mine. Part of our job is to record daily bowel movements on those bowel movement sheets, they're called, graphic records. When you do that, you alert the staff on different shifts that indeed that person's bowel is functioning normally. If you or I forget to note this daily, and those spaces are blank on the records, 2 or 3 or 4 days later, somebody's going to look and say, well, it's time for an enema or a laxative. They haven't had a bowel movement. When in fact they have, you just haven't recorded it. Another sign that you might find that a person is impacted is that when you wash them and give perineal care, you find that they're oozing or draining liquid stool. This is not incontinence so much as simply losing stool around that chunk or impacted piece of stool. Many of these people lose their appetite, and perhaps you've been losing your appetite at this point. But these are people whose appetites are really failing them, and not just momentarily. They're restless. They may have abdominal cramping. They may also, of course, have some nausea and feel like they're just not feeling up to their own normal self. For some elderly, this might be a cause of confusion as well. Now, as I said, impaction usually requires the assistance of an enema or a much more powerful force than just taking somebody to the toilet to solve. There's one more problem that we need to talk about, and usually this is the problem, the opposite of constipation is diarrhea. And real quickly, just to mention that diarrhea is the frequent passage of liquid or loose stool. It is one very quick way for the body, especially the older body, to lose fluids and to become dehydrated. When we have diarrhea, it's extremely important that you replace that fluid with additional water. Usually water, anything liquid is going to help replace that, because this is now water that will not be reabsorbed by the body. When you have somebody with diarrhea and you're taking care of them, be sure that you have extreme attention paid to the skin care. The gastric and intestinal acids are now going to be on that skin if you don't wash that off. They will have very red-skinned, it will be raw and very sore. Make sure that when they do have diarrhea, they have to go to the bathroom quickly, that you get them there quickly. And sometimes we just leave the commode or bedpan right at the bedside to be ready. And of course, this person is most always on intake and output recording as well. In another session, we will discuss the topic of incontinence, which is the involuntary loss of not just urine, but sometimes also stool as well. This can be a result either of nerve damage, again, when the nerves that we depend on to take the signal that we have that need to go to the bathroom, and that takes us to the toilet. If those nerves are not functioning, we don't hear or get that signal. And then also, sometimes as we get older, those muscles do get weaker, and stool is apt to escape without one person knowing it. There are many problems that we could talk about here when we talk about bowel care, but I think one of the things we would want to look at and review real quickly is that you as a nursing assistant have a definite role here. You're going to spend a great deal of time with skin care for these people, with changing incontinence briefs, changing linens perhaps. You're going to spend a great deal of time washing your hands after toileting these people. You are going to also remember wear gloves as part of universal fluid precautions, simply to protect yourself from microorganisms that might be found in body fluids or discharges. I can't stress enough the importance of reporting and recording. Certainly you report the unusual findings that you see, but remember you must record those every single bowel movements on those graphic sheets. It is part of keeping that patient from having to go through enemas and laxative needlessly. Be sensitive in addition to what that patient is feeling. Can you imagine what it's like for somebody to have to do all of this in front of a group of people watching? Most patients do not do this in open public. It's a very private function, done in the bathroom and for most people with the door closed, and nobody else helps them with it. So keep in mind that when a person is incontinent or they're having trouble with their bowels or they cannot get themselves to the bathroom, they cannot help themselves, you will be required to help take care of this. And I know as a nurse I have found this experience one that I have had to get used to, and you do get used to it. I will just give you that clue right up front. However, I suggest that when you get started, you just give it your best try. And perhaps the first time you have to empty that bedpan or change the commode or take somebody to the toilet like this, think about something else. Yes, I know you're going to be thinking about what you're doing, but instead of concentrating so much on what's in the bedpan, think about what am I talking about with that patient, what am I going to be doing next, and get your mind off of what's in front of you in that pan. That will help a great deal. So I wish you well now as you go on and learn to take care of people, and especially to take care of their bowel elimination needs, it will be a challenge for you, but one I think you'll rise up to.
A caregiver may have to deal with a variety of difficult situations at mealtime when caring for a resident with dementia. For instance, the resident may have a change in eating habits. They may not remember meals or may no longer be aware of a mealtime schedule. And this can be a problem when family members or friends stop by to see them and they'll say they haven't eaten in a few days, even though they just got up from the table. They may have an increased interest in food. They may have more rigid likes and dislikes. They may prefer familiar foods cooked in familiar ways. New foods could confuse them, or they may no longer retain those lifelong preferences and may have little or no interest in food at all. In this next personal care area, which is eating, Ginny provides us with helpful information that will make mealtimes a more enjoyable experience for both the caregivers and the residents alike.
This nursing assistant teleclass will concentrate on the topic of food and fluids in terms of helping people with their feeding or their eating time. When we talk about helping people with their meal time and when they have to be fed sometimes, and certainly when they're going to eat, we must consider that food oftentimes has social connotations or social atmosphere, so to speak, because we do sit and usually have a conversation or have our meals with other people. We know too that food can often take the blame when people are unhappy. It's easy if one is upset or depressed or feeling poorly to blame the food, to take it out on the food, so to speak. And you might hear comments like, "This food all tastes the same," or "We get the same old thing all of the time." You might want to just know ahead of time that sometimes patients find food a very safe thing to get angry at. One of the most common things that a healthy person does prior to a mealtime is to take themselves to the bathroom or toilet. And I think sometimes you realize, again, these are things we think very little about. They just sort of happen naturally. But the person who is unable to do these things for themselves now requires special attention, and you must think for them. We want to make sure that they're properly clothed. In the morning, perhaps they wear a bathrobe. Man might have his robe on. As well, we know that if people are eating in a dining room, in a social area, gathering place, they need to have street clothes on. We know that we must also make sure that the face and hands are clean prior to a meal. And many people will use maybe handy wipes, just simply to wipe the hands and to wipe the face. However, many times these disposable wipes or paper wipes are not adequate, and then you will need a towel and a washcloth. Oral hygiene may be very helpful for the person who has a poor appetite to help refresh their mouth and make food taste better. The person should, when you start to prepare them for their meal, also be in a sitting position, in an upright position. This means that they're less likely to choke, that food is less apt to get stuck in their throat. If they're in bed, we want to make sure that the head of the bed is elevated to at least a 60 to a 90-degree angle. That's sitting up pretty high. We want to make sure that we have a pleasant atmosphere or environment. Think about such things as odors that might be in the room. Sometimes wound drainage or dressings or leftover underpads or chucks need to be removed from the area. We want to make sure that the person is comfortable both physically and psychologically. And oftentimes, in my experience, I'll see that there's a urinal at the bedside and it's right in full view. And oftentimes you'll see that the man has perhaps placed the urinal on his bedside stand or over bed table, right where you're going to put their tray. It would be your responsibility to take care of that urinal or the bedpan if that's there as well. Another thing that many of us take for granted and probably don't think a whole great deal about is the fact that people need to have their teeth in if they're going to chew their food. Now, this sounds simple for you and I. However, if you're bedridden and the teeth are not in, and they might not be in for various reasons, you might need to put those in. So as we talk about preparing the patient or the resident for a meal, think about the things you would automatically do for yourself, and now we in turn must do those for that other person. When we talk about serving the tray or the meal, What are some things now that you must do? One of the most common things that healthcare workers just do all the time is to check to make sure you have the right patient. And how do you do that? There are quite a few ways. Many patients wear identification bands on their wrists, and you would simply look at that to see if you have the patient that you are indeed bringing the tray for. We might also call people by their name or ask them to tell us their name. Sometimes their name is on a name tag, such as they might wear on their clothing. Perhaps you have to have another staff member help you identify a patient if you're new in that facility or if the patient themselves is new. We also must make sure, in addition to checking for the correct patient, that we have the correct tray. Oftentimes, trays will be delivered on carts. These are trays that are stacked in hot, warm carts which are made to deliver the food in a nice even temperature. And each tray should have some type of identification on it. Either a piece of paper or something that is very observable as to who the tray is going to go to, I should say. When you check the tray, you also want to make sure that everything is there. Many times we find such things as a cup is missing, perhaps there's a glass missing for the milk, or perhaps for containers such as milk cartons. We also might find sometimes that a piece of silverware is missing. It would be up to you to make sure that those pieces that are missing are replaced so the patient can use them. After you have checked the patient, you're sure you have the right person, and you know that you have the right tray for that particular person, you want to bring it and put it literally in front of that person so that they can see it. Now, when we look at food, we know that a lot of our appetite and taste is related to how we view food, how we see it, to our imagination. If I say to you right now, I'm going to give you a donut, chances are good you can picture some kind of a donut, and doesn't it taste good already? I bet. But what if I say I'm going to give you a piece of liver for your meat for the meal tonight? I think some of you might have a different idea, and you don't even have to see the food. You already know by what I'm saying that food has different feelings, so to speak. Food has different, well, should I say, emotions, and they connect in all of us. We all have certain preferences. So it is important that the patients see the food and, of course, build up this chance to, boy, I can't wait to get at that donut. Or they can say, I don't like it and I don't want to eat that. I'll have something else. So placing the tray in front of the person is an important part before they ever start eating. We want to make sure that that tray looks appealing. Now, what do I mean when I say looks appealing? Have you ever had somebody spill milk or coffee all over the tablecloth or a tray that you're about to use? That does not look appetizing, not to mention the fact that you have lost the liquids that that person either had hoped to drink or use or should be having. We want to make sure then that the tray looks appealing, that it looks good. Certainly, and I've seen this several times, as you take trays and walk down a hall with them, it's easy for fluids to spill. So you will have to develop the ability to carry that tray without spilling fluids. However, I've seen several trays where the whole cup of milk or coffee went into the plate. When those things happen, there's no way you can repair that, and you simply have to call the diet kitchen and get another serving, another plate with the food on it. Once the food is in front of the patient, now what do you want to do? Can you think of some things that you'd want to do if you see some meat in front of you, if you see the carton of milk or bread needs to be buttered? What would you need to do if you know the patient cannot use their hands to do it for themselves? I think you'd probably very quickly imagine that you might have to cut that meat, open the carton of milk. You're probably going to have to butter the bread or the toast. If the egg is a hard-boiled or soft-boiled egg and it's still in the shell, you will have to open that egg and scoop out the egg. You may have to mash the potato if they have, say, a solid or a boiled potato in front of them. Sometimes you find that you do have to cut things up, such as fruit, maybe a pear, or you may have to cut up sometimes the vegetables so that the patient can easily get them on their fork or on their spoon. What we're asking you here to do is to think ahead. What type of assistance does the patient need in order to help feed themselves? I think it goes without saying that you want to serve the food while it's still hot. We know that it's much more appetizing if the food is warm or certainly at a comfortable eating temperature. We know that cold food is just not tasty or appealing. And not to mention, if food has been sitting around for a great period of time, it can be a source of food poisoning or infections caused by bacteria that are growing in that food. And then I think, too, as we look at serving food at its proper temperature, some things need to be said about cold foods. Ice cream is not usually eaten when it's all melted and runny. And sometimes we have to pay attention to the frozen foods or cold foods on the tray as well. Perhaps that ice cream must be kept in the refrigerator or the freezer until the patient is ready to eat it. One of the first guidelines to consider when we help people with their feeding is to try to look that you make the appearance that you're not rushed. Try to look unhurried. Now that's difficult to do if you have a lot of trays to get out, if you have a lot of people to help feed. However, what you usually want to do is to make sure that there is somebody assigned to help feed people who require feeding. And this way, the planning is done ahead of time as to where everybody will be at mealtime. But you should try to be unhurried, not rushed, and to sit down and have pleasant social experience with that mealtime. We want to make sure that the patient is as involved as possible for several reasons. We want to make sure that we use devices if necessary. The patient can probably use this, him or herself can use something like this to help feed. Perhaps they do nothing more than just hold a piece of toast that they have on their tray while you feed them the eggs and their coffee. Keep in mind that whenever the patient does feed themselves, they are using their own muscles and joints and bones, and this is to their benefit. It also helps to promote independence and a feeling of self-worth and control. So you want to encourage that patient as much as possible to be involved in feeding if it's at all possible. One of the things, too, that we know about feeding other people is that when you feed people, it sometimes is difficult if you're standing across from somebody and now you have to, in turn, put the food in someone else's mouth. Many times we use a spoon, simply because a spoon is easier to hold the food. And then when we use the spoon to go into someone else's mouth, we put the spoon in point first. So the food would go in from the spoon in this direction, not from the side of the spoon. It's too easy to spill around the edges. We also know that when we use a spoon, we don't want to have any more than a half full, or certainly not a heaping spoonful of food going into that person's mouth. So a spoon is a very handy device to use to help feed other people. We want to make sure that when you do feed people, that you alternate foods and fluids so that the person has a chance to not, what should I say, have all the dry foods and find that they just simply can't chew and swallow. Most people like to alternate. We also know that we want to help that person swallow, and the fluids will help that person to swallow. How do you test for hot things? Well, one of the things that you will find yourself doing is simply feeling the outside of the cup. And if this feels very warm to your hand, you know that it's going to feel warm to that person's mouth or lips. Keep in mind that you do have to be alert to serving something if it's too hot. Another way that you can test the temperature of that is to, with the patient's spoon, simply dip some of the liquid from the cup and just drop a few drops on your wrist. And your wrist is a very sensitive area for testing temperatures. What you do not want to do, and I think I should say this because I unfortunately do see people do this, you do not blow on that person's food to cool it for them. If they want to blow on it, that's fine. And you do not taste the food for them. They can taste their own. And sometimes you simply just tell them that the food might be hot and just lay it against their lips for them to gently get the feel of the temperature. They can tell you if it's too hot or not. So keep in mind you do test for temperature, particularly hot temperatures. When we deal with the older person, remember, some of these people like to take their time. We also know that sometimes they tire easily, and to eat a lot of food or to eat a whole meal at one time can be very tiring. So you do plan that they will chew slowly, that they will take their time usually. And remember, for them, for anybody basically who's a patient, a meal time should be an enjoyable time and not something to be rushed through. For many people, this is the highlight of their day when they get their 3 meals a day. And they need to enjoy that time. So if they wish to take their time chewing and enjoying the meal, for goodness sakes, let them. That's to your benefit. However, as healthcare workers, if we're feeding somebody, and you do feel rushed sometimes, you want to keep in mind that the faster you feed somebody, the more they're apt to choke. Not to mention the fact they'll probably stop and just don't want any more after a certain point. So allow them time to chew, to thoroughly chew their food and to swallow it. Sometimes when you're feeding people, they make a pretty good-sized mess. If they have Parkinson's disease or difficulty controlling their movements or their hand, they may be very quick at losing more food sometimes than they probably take in. And the dietitian usually accounts for this problem. However, I think in all fairness, it's for us to pay attention to here that intake is much more important than the neatness and the appearance around them as they're eating. Usually people that have a great deal of difficulty eating and making a large mess, or who are uncoordinated in their movements, probably prefer to eat somewhat off to the side of the dining room or with other people who are also having difficulty. Now, something else that you must do as a nursing assistant when you help people with their feeding. We know that there are certain problems that can arise, and you must be constantly aware of coughing, of choking, and people who have swallowing problems. You can tell if they have swallowing problems because the food will usually drool or come out of their mouth before they can really swallow it. Now, as long as somebody can cough or speak or make noise, and that tells you they're getting air, if they do get something down the windpipe perhaps or into their trachea, I think you will find that if you can let them cough, even though it sounds terrible and it sounds like they're not going to make it, as long as they can cough, they will probably have a much more effective time of clearing that airway than if you were to do anything right now at that point. Many times we're tempted to really pound people on their backs in order to, while they're coughing, in order to help them clear their throat. But you really need to let them do the coughing. That's nature's mechanism for clearing the throat. The blind person requires some additional assistance. And think about it for just a minute. If your eyes are closed and you simply can see nothing in front of you, what would you do? How would you help that person to envision or visualize what's in front of them? Well, several things you can do. One is to describe the location of the food on the plate or tray in terms of the clock. If I were to ask you right now to close your eyes, you could envision where 1 o'clock is, or 4 o'clock, or how about 8 o'clock, or 10 o'clock. And if I said the potatoes were at 2 o'clock, and the meat was at 6 o'clock, and the vegetables were at 10 o'clock, could you picture that on somebody's plate? Most times when we deal with the blind person, we do use the clock as some type of a way to describe where the food is. And then if you are feeding the blind person, you want to make sure that you describe to that person what it is you are giving them. Tell them, here comes your vegetables, or this is your broccoli, this is your applesauce, so that they have an idea of what to expect. One more consideration in helping people with feeding: if the person has had a stroke, we have another problem to deal with. The person who is paralyzed on, say, one side of their face very likely also has one side of their tongue paralyzed. That tongue then on that side is unable to feel or to help move food around in the mouth. For this particular person, you want to place the food on the strong side or the non-paralyzed side of the mouth. This will help that person to swallow the food and not find it being held in the cheeks or in the mouth. What now about follow-up care after the person has eaten? Well, not too difficult perhaps. You want to remove the tray, certainly to put it back in the proper place where it's going to be taken back to the diet kitchen for cleaning. Important that you note what was eaten. And many times we find we describe things as the patient ate all of their food or half. We might say that they ate well or ate poorly. We might also describe in terms of percent. They ate 100% or 50% of their food. And most places have an appetite record that you will be required to write on for every patient when you pick up a tray. Important too that if there are liquids that you notice what has been taken. Remember, we need 2 to 3 quarts of liquids in a day, and the person should be taking all of their liquids at the mealtime, as well as, of course, in between meal snacks. If they're on intake and output, you will have to record that on a particular paper. Always make sure their face and hands are clean after they eat, and sometimes you do have to change their clothing as well if they've spilled food on their clothing. Make sure that they've had oral hygiene. Many times after food has been eaten, the teeth and the mouth need to be refreshed, as well as, of course, if they haven't toileted before meals, chances are very good they will have to use the bathroom after the meal. So you do have some preparation as well as some follow-up care when you are going to help feed people. Another topic that we need to just briefly address here is the one of serving nourishments or water, fresh water. Usually this is what you as an assistant will do at the mid-morning point or mid-afternoon, as well as just prior to bedtime. Things like juices, maybe a snack like cookies or crackers. Perhaps you'll find some people would like a glass of milk or other types of liquids that are usually used as snacks. This, of course, would be recorded for those that are intake and output. And I might just mention here, too, that should the person be a diabetic, that nourishment must be carefully controlled, and usually the diabetic person has a very particular snack that is just for that person. Whenever the person is confused or unable to get up, or perhaps they're on bladder training programs where they require additional fluids, you must take it upon yourself to make sure you do get these fluids to that patient. I might just review here again that sometimes you do have patients who are on force fluids or encouraged fluids. And this means that you want to offer them basically as much as they will take throughout the daytime or waking hours. If they are on restricted fluids, then they usually only get what is served at the mealtime. When it comes to fresh water, each facility has a different policy. But you will find that many times water is kept at the bedside in a carafe or a pitcher, and you will be required to change that periodically. You also will be required many times to wash those containers, as well as to make sure that the glasses and what the patient drinks from is kept clean as well. We will ask you to look up the policy in your facility to see just what you are expected to do when it comes to passing fresh water. Again, I think it's important for you to know here as we conclude this tape that you as a nursing assistant are indeed the eyes and ears for that nurse. You are expected to continually observe and watch and report what you see back to the nurses. Gradually, you will become more comfortable working with them. And I think you will find this a very satisfying experience, and one certainly that the patients will appreciate.
This next area of personal care is something we do every day without much thought and that we sometimes take for granted. The CBRF regulations refer to it as manipulating objects. Manipulating objects refers to the skill and performance in handling large and small common objects such as light switches, doorknobs, forks, spoons, cups, water faucets, toilet seats. Manipulating objects is something we do every day. We take for granted our ability to open a door, turn a light switch on and off, dial a telephone number, open a package, or even turn on a television or a radio. The resident with dementia suffers from an ongoing brain damage that can affect their ability to manipulate small and large objects. To complicate matters, the resident with dementia may have other conditions that are related to aging, such as arthritis, Parkinson's disease, heart disease, and diabetes, and that may further disable them.
A resident with dementia may not be able to manipulate objects for a variety of reasons. Some of these reasons are that the brain may not be able to get the body to do what it wants. They have an inability to understand what is being said. They have a very short attention span. They have a loss of motor skills and inability to move their body the way they want to. They have a lack of depth perception, and this can be a very great one when they're trying to pour something or put something down. They have an inability to recognize familiar objects, and they have an inability to recognize right from left, hot from cold, up from down. They also have an inability to interpret or to interpret correctly what they see, what they hear, what they smell, what they touch, and what they feel. This reminds me of two residents, particularly one who could manipulate the door key code. He was not doing it appropriately because he got himself out of a secure unit. So even though we say they're not able to manipulate, sometimes the correct interpretation is what we need to work on with the resident. The other one was a resident who very carefully walked up to a fire alarm and followed the directions very clearly, broke the glass and set off a fire alarm in the nursing home. So that the manipulation is one thing, but the interpretation of correct manipulation is something else that we have to be aware of.
Dementia may affect each resident differently, and each day the resident's ability to manipulate objects may vary. It takes a great deal of observing and assessing a resident with dementia to determine why he or she is unable to manipulate an object and what you might do to assist him or her while still permitting them to have as much independence as possible. Reasons for manipulating objects include to complete activities of daily living, to maintain physical and mental function, to maintain mental and physical well-being, and to stimulate circulation.
General guidelines for manipulating objects are some things that we need to consider in the way that we give directions to a resident. I think it's important that we think how we would react if I were treated the way I'm treating this resident. When we're giving them directions or suggestions, I think we need to keep that in mind. Safety should always be the first consideration. Don't allow a resident to manipulate any object that might be a safety hazard to him or to her. Be supportive of the resident's dignity and self-esteem. Focus on what the resident can do, not on what they cannot do. In other words, John, you did that well, rather than, John, look, you made that mistake again. Use simple verbal cues, speaking slowly, clearly, and gently. Wash, it's time to eat now, sit down, turn here. Use simple visual cues. Demonstrate manipulating the object yourself, and it's important that you do that slowly and clearly within the resident's line of vision. Use a hand-over-hand demonstration to get the resident started. In other words, put the resident's hand on the object and your hand over it so that you can assist them in the manipulation. Break down the task of manipulating objects that most closely resembles the way a resident would use the object. Ask family members about objects that the resident is familiar with and what the resident called that object.
Remember to be patient and not to rush your resident. Give the resident plenty of time to process any verbal or visual cues you are giving to them. Give the resident plenty of time to complete the manipulation of the object. Ask yourself these questions. Could the resident's physical, mental, or emotional health be a factor? Has the resident been evaluated or assessed for dementia? Does the resident have pain? Is the resident ill? Is the resident able to see objects well enough to identify what they are and to use them appropriately? Can the resident hear the verbal cues you are giving to him or her? And is the resident taking any medication that might impair their alertness, the steadiness, or the level of function? Is the resident dehydrated or constipated? Is the resident hungry, or are they getting enough sleep? Does the resident need to use the bathroom? Could the resident be depressed? Is the resident taking any medication that is causing him or her to be drowsy, depressed, or overstimulated?
Is the environment causing confusion, agitation, and restlessness? We all have a different ability to tune out noises that are not important to what we're doing at the time. The resident with dementia does not have that ability. Is the environment unfamiliar to the resident? Is the area too large and too overwhelming for the resident? Is the environment too cluttered for the resident? And in that way stimulates the resident too much. Is the resident confused because there are too many competing noises and activities in the environment? Are you trying to have the resident do something when a radio is playing a short distance away and in the next room the TV set is on at a window splitting level?
Is the task causing the resident to be confused, angry, or frustrated? Is the task too difficult? Has the task been broken down into the simplest steps possible? Are there too many steps? Has the task been adjusted to the resident's impairments? Is the task familiar to the resident? Is a familiar caregiver assisting the resident? And are you following a routine? Are you providing simple, familiar verbal and visual cues? And are you rushing the resident?
Is communication a factor? Do you understand what the resident is saying to you? And does the resident understand what you are saying to him or to her? What are you communicating to the resident with your body language? Sometimes if we fold our arms or sigh or tap our toes, we're giving the impression that we wish the person that we're speaking with would hurry up and finish what it is they're doing. The resident with dementia is going to pick up those same signals. Is your tone of voice upsetting the resident? Are you asking questions the resident cannot answer? If you have communication strategies that work, document them so others can use those familiar patterns with that same resident. Observe, report, and document the changes in the resident's physical ability to manipulate objects, changes in his mental ability to manipulate objects, methods that have worked for you in getting the resident to manipulate objects, and problems manipulating the objects that the resident has reported.
Manipulating objects, supplies, objects that are used during the course of any given day, simple verbal cues and simple visual cues, signs, labels, pictures or photos, even objects would help. You want to do a task breakdown and a familiar caregiver that the resident responds to positively would help.
The procedure when the client is manipulating objects has to be an organized one. Explain the procedure to the resident, have all supplies ready, break the task down into simple steps. Use simple verbal or visual cues. Do not rush the client. Demonstrate the manipulation of the object. Start the resident out by using the hand-over-hand method of demonstrating, and praise the resident and give reassurance often.
Now that we've assisted the dementia resident with bathing, dressing, toileting, and eating, how are we going to safely assist them with ambulation or moving about in the CBRF? When a resident is frail and elderly, they may have difficulty walking and getting about. When you add dementia to being frail and elderly, it becomes even more difficult. As we discussed earlier, sometimes the brain of a resident with dementia cannot get his or her body to do what it wants to do. The resident may become awkward and unsteady as a result of ambulating, and the ambulating may become more difficult and unsafe. Ginny, her friend Lorraine Bartholz, and physical therapist Scott Kagan will now demonstrate various methods and techniques of assisting your residents with safe ambulation, including walking and moving about.
Restorative care often will involve your assisting that patient to get up and move about. And for some of our people that we're going to work with, this is a very difficult process. They are going to have to use added help from you. They're going to have to use such things as transfer belts. They're going to have to use such things as walkers, canes, and crutches. And many times they're just simply going to need you to stand by to encourage them and support them emotionally as well. Now, moving, lifting, transferring are common tasks that you as the assistant will be asked to perform on any given day and on any given shift. I need to remind you that before we talk about this, that you actually review again body mechanics. Now, body mechanics, remember, involve how you use your back, how you use your legs. They, of course, mean that you bend your knees and your hips. You do not bend your back. You use the long and strong muscles of your arms and legs. You work close to your center of gravity. You do keep your feet at a good base of support. And I think you need to go back at some points and review those good body mechanics principles. Now, make sure that you do use body mechanics simply for no other reason to prevent yourself from being injured. Now, I know if you keep that in mind and you use good body mechanics, you will also maximize your strength, you will reduce fatigue and being tired, and at the same time, you will reduce the chance of injury to your patients as well. Now, when I talk here about helping a person to ambulate, we're talking here about various devices and how these are used. But before we actually go into the nursing lab and take a look at these various aids to help this person ambulate, I want to take a look at some terms and some general principles. The term ambulatory really means that that person is able to walk around. So as I use the word ambulatory, just you could maybe put another word called walking in there. So if the person is ambulatory, they're able to walk. I want you to keep in mind too that if that person is able to get up and move around, even if it's just for a little tiny bit, that's going to improve their strength, their use of their own muscles. So any help that you can give that person to encourage them to be movable, to get up and to ambulate, even if it does take them a lot of effort with their walker, is really going to pay off in the long run. But before we actually see how we want to walk our patient, a couple things you need to realize. Before we can actually do the task, remember we have to plan our work and make sure that we're all set to do the job. First of all, make sure that as you are walking that patient, if they have a catheter bag, the bag that holds their urine, make sure that that bag is covered. If they're going to take that out in public, they may feel much more comfortable if that bag is covered perhaps with a towel. Some places have bags that actually cover that urine drainage bag, and it looks much more attractive. Now, certainly everybody knows what it is, but at least that person's urine is not on public display. Make sure that all clothes are secure, are fastened, that they're buttoned, that they're zippered. And I think an important one that I find, it seems recently I've seen quite a few instances of this. Elastic waistbands that are pretty loose and the pants or trousers fall down. Or I saw this one poor gentleman, he was walking down the hall and his trousers gave way. He had lost a lot of weight, the belt was still pretty big, and the whole outfit just simply slipped right over his hips. Now, he should have had trousers that fit a lot better, and certainly the belt could have been snugger at least. We also know that sometimes we'll see ladies walking down the hall, and especially if they have a dress on, their incontinence briefs are falling down. Plan ahead of time so these things do not happen. It's not only not dignifying, it certainly is a hazard as they perhaps trip and fall over it. Another thing that you need to think about ahead of time, remember these people are going to walk, and when you walk, remember, you use your feet. Consequently, you want to make sure that they have sturdy shoes on that fit well, not slipping up and down as they walk, and are tied or laced in position. Make sure that they also have soles on the shoes that are non-slip, that are not going to skid. And then also make sure that you know how far you are going. As you take a walk with a patient, remember usually when you go someplace you also have to come back. And you want to make sure that patient has the energy or the stamina to do that. If not, make sure that there's a rest point someplace in there for that person to stay or wait until they have the energy to come back. You want to make sure that for many people this is a pleasant experience. Perhaps you take a walk every day in the same place. Now, if that's what the patient wants, that's one thing. But I think sometimes it pays to turn the opposite direction when you leave that patient's room. Give them another view, so to speak, of what's around them. You always want to be prepared for falls. Now remember, a fall is an unexpected event usually, but you can prepare ahead of time for it, making sure that you do use the transfer belts or the gait belts to hold on to people to help give that little added bit of support. Making sure that you walk closely to close by that person to catch them if they need stability. Making sure that indeed you do take chairs or wheelchairs with you if that's necessary for that person to sit down periodically. If you do happen to fall, a couple things. Many times I find that if that patient knows they're going to fall, they will tell you ahead of time, and you grab the first available chair or the first available person to help you with that. And of course that way the two of you can help guide that person to a safe spot. You also might find that if the person is going to fall, you might want to have them lean against the wall, and you can thereby help slide them down to the floor that way. Now, if a person is going to fall, and they're already in the process of falling, and remember this happens quickly, our first reaction many times is to try to hold them, to stop them, to keep them from falling. And many times what happens is we hurt ourselves instead. The heavy twisting, trying to carry or lift someone else, sometimes this involves jerking and straining of muscles, oftentimes put you in a bad situation just as well as the patient. So be very cautious if you try to stop a fall. Only do it if you know that by controlling the transfer belt or what you have your hands on, can you actually stop that. I think you'll find though that falls are kept to a minimum if you do practice good safety principles ahead of time and plan for what you're going to do. Now, in the nursing lab, Mr. Scott Coggin of Rehabilitation Associates, who is a physical therapist at Rocky Knoll Healthcare Facility in Plymouth, will demonstrate some of the pointers that we need to know about helping this person to ambulate. He will talk to you about various devices such as the gait belt, the walker, and the cane, and the crutches. But as we watch Scott, I would like you to pay attention to how he uses his arms and legs, how he positions his body, the way he supports himself by the placement of his feet, and also the things that he actually does to help Lorraine, the nursing assistant participant in this demonstration, become a safe walker. So let's go into the nursing lab then, and we'll see what's going to happen.
What I'd like to cover now is just helping people walk with different devices or maybe even without use of an assistive device. Very important to try and keep people as mobile as possible for the psychological aspect as far as the person having to depend less on others for their mobility and getting around, and also for their physical benefit. It helps to maintain their circulation, their cardiac status, their pulmonary status. It helps to keep their bowel and bladder functioning, going at an optimum level. It helps to preserve their strength and their endurance. It reduces their risk of such things as pneumonia, contractures, decubiti, just through the act of being mobile. And what we're going to do is show you different ways to help a person walk if they're starting to regress and start needing some assistance. There's different things to help a person walk. They may not need anything other than just somebody standing by if they have a little balance problems, or they may need a great deal of assist with a walking device such as a walker, and we'll cover different things as we go along here. One of the first things you want to do whenever you're walking with anybody that requires any type of assistance is to always use a gait belt. Very important to use this device. It's one of the most important devices that you'll use. Very important to use it properly. This device needs to be placed approximately the waist level, about where you'd wear your own belt. You're going to try and keep the buckle out from the center areas. Try and keep to the side or slightly behind the individual. Secure it snugly. And if you have a tail, just want to loop it underneath so it's not in your way. All right. When you're walking with a person, you want to make sure that you have at least one hand on the gait belt at all times. And generally, you have real good control of an individual if you have it about the mid-back. Okay? And turn back. Also, whenever you're walking with an individual, if a person has a slight deficit on one side or the other, it's best to walk on the person's affected side. That if a person has had a CVA, or maybe they've had a broken limb, it's best to walk on that side that's affected, because as a general rule of thumb, if a person's going to lose their balance, they're going to lose it towards their affected side. So always walk on that side unless you've been specifically instructed otherwise by a therapist, a nurse, or the physician. When walking with a person or gating with a person without an assistive device, again, you want to walk on the side. You don't want to be ahead of them or too far behind, but more at the side, and just walk straight ahead. Sometimes the person may need a little assistance, and you can offer them your hand. It's best to offer them a hand like this so you have a good support. They're grabbing your thumb, and your palms are together, and you've got a nice base of support for them. And you're just walking along, again at the side, and turn, and back. All right, very important. If a person's had a fracture of the lower leg and perhaps they're convalescing from that, if it's in the early stages of their recovery, before you walk with that person, you want to make sure that there aren't any weight-bearing restrictions, and if there are weight-bearing restrictions on that extremity, that you follow those closely. A lot of times surgeons will go in and put different devices to help secure the bone fragments in place, and those can take some stress, but up to only a certain point. So it's very important that you know what those limitations are. As far as walking with a person, another important aspect is footwear. The person needs to be wearing something with a good sole on it and that fits snugly, so that the person isn't going to lose their balance because of their shoes or to slide on the floor or whatever. Okay? Some of the different devices that we're going to use to help a person walk. A real common and typical device is the walker. A walker has 4 legs and is typically a very stable device. Offers the person a lot of support when they're pushing the downward position. It is very tipsy though when the person is coming to standing. You cannot allow them to pull on the walker to come to a standing position because there's nothing to hold it down. So very important to have them grasp their walker or their whatever their assistive device may be after they've come to a full standing position. As far as making sure that the walker or the assistive device fits right, there's just a couple of general rules of thumb that apply to all the different devices. And as a rule, the general fit comes to about the level of the trochanter or the hip bone, or if the person's standing erect with their arms at their side, that point also comes approximately the crease in their wrist. Okay? And when you have the device fitting properly, I'm going to adjust this one just a little bit lower. Most of the devices on the market nowadays just have simple push buttons that allow you to adjust quickly. You just push the button in, push the leg down until it snaps in. Sometimes you have to wiggle the leg a little bit for it to pop out. Again, check the height of the device. If you're standing, the grip is at approximately the crease of her wrist, approximately the level of her trochanter. When she puts her hands on the device, if you'll turn sideways, the device, and she's standing with the device slightly ahead of her, you'll notice that there's a slight bend in her elbow. Just grab it. Is it comfortable? It should be approximately a 20 to 30 degree bend in the elbow. Slight bend. With any type of device, the general sequence of events, you want to move the assistive device ahead to about the straightening of the elbows, a comfortable arm's length. step ahead with the affected leg, step at the right, and then catch up with the good limb. Again, the walker or the assistive device, the affected limb, and the good limb. The reason for this sequence, and moving the affected limb ahead first, is when you move the affected limb ahead, it forces the knee into a straightened position and effectively locks the knee, so long as they don't have any complicating factors such as knee contractures. If the person has good motion of the knee, that knee will lock. You have a very stable leg on which to support yourself as you advance forward. So that's the logic behind the sequence of events when you're walking with someone. That's walking with the walker. Same sequence can be used with a cane. Again, you want to check the height. This is a little high. She's got a real severe bend in the elbow. So we'll lower that. Okay. She's got a slight bend in the elbow. We'll pretend that her right leg is the affected limb, so we'll use the cane on the opposite side. When you're using just a single support, your device should be on the unaffected side, opposite of the involved side. Again, you move the involved side ahead first. You lean on you have the device on the unaffected side, so you have a support. You get the knee locked, and then you advance with the good. Okay. You want to strive for nice equal steps as you go along. One foot should advance just as far as the other foot. We'll back up and we'll go through that again. Advance the right foot, the cane, and now the left foot. Get it far ahead, get it ahead as, there you go. Like a normal sequence here. That's fine. When a person feels comfortable with that, they can move the affected extremity and the cane at the same time if they feel more comfortable with that. Okay? We'll back up. The other device that you'll be instructed in are use of crutches. There's a couple different types of crutches on the market. These are called Canadian-style crutches, just as a term, forearm crutches, whatever you might want to call them. These devices work just as effectively as the other standard wooden type of crutch. They just don't have the piece coming up along the trunk. This cuff should come just below the elbow. This fits well. We're using crutches. Same sequence of events occurs. You move the crutches ahead. Move the affected leg, then you move the good leg. Step all the way through. Good. Crutches, not too far. Just straightening of the arms, comfortable length, and ahead. Move the left foot ahead a little bit further. Good. Okay. The only difference between fitting of these style of crutches with the wooden crutches is that you have to take into account the height of the portion coming underneath the arms. And when you fit a person with the wood crutches, or any type of crutch that comes up under the arm, when the person's standing erect, with the crutch tip slightly ahead of the feet and 6 to 8 inches out to the side, you want to be able to get 3 to 4 fingers between the armpit of the person and the top of the crutch. These ride very high into her armpit, so you'd have to adjust these to a point that you'd get 3 to 4 finger widths underneath. You do not want the person leaning on the tops of the crutches. You have a lot of your main arteries and nerve supply to the rest of your arm that comes through the underarm area, and if these are impinging that area, you may have some tingling, some circulation problems and whatnot. So you want to make sure that you've got adequate clearance underneath these. These This portion of the crutches should be resting more against the trunk of the individual rather than riding up into the arms. And if you see an individual leaning forward onto these and riding way up into the arms, you want to remind them of the dangers of that and to make sure that they're standing erect. If a person typically assumes that type of a position, they may be more appropriate for the other style of crutches. With any type of assistive device, you want to make sure that the tips of the device are in good condition. Kind of turn the device upside down. Make sure they've got good grip. Make sure that they're not smooth and worn. Make sure that all the tips are in their proper place. With the walker that we were using, we were missing one tip. So you would not want to use that walker for that individual until you get that remedied. Also with this walker, the tips are somewhat worn and rounded, so ideally all 4 tips should be replaced before you would use this with an individual. Just important to remember that when a person comes into a facility or you're asked to go get a walker for an individual, perhaps from the storeroom, or perhaps family members have brought in an assistive device for an individual for their use, to make sure that the device fits properly. Very important. Very common to just have a walker sent up and just have the person start using it without consideration of the fit. So it's very important on your part to check on that yourself. Again, that fit, the handle should be approximately the height of the trochanters or the level of the crease of the wrist, so that as the person's standing erect with that device, you have a slight bend in the elbows. The other thing I'd also like to review is to make sure that the gait belt is applied properly. There are a variety of gait belts on the market, and it's very important that you're familiar with the gait belts that are used within your organization. A very common device that's used is the strong web belt with the metal buckle that has a serrated edge on it. And as you place the gait belt on the individual, again, waist height with the buckle at the side, you want to loop it through so that the webbing comes through. And then as you pull the webbing back, that webbing is forced against the teeth of the buckle so that it holds it securely in place. Get it worked through, check the snugness, check the location of the buckle so that if some sliding of the gait belt should occur as you're helping the person come to stand, or if the patient should start to lose their balance and it should slide up if you don't have it on snugly enough, that buckle doesn't ride up into the rib cage or into the upper torso of the individual. And again, just remove any loose ends. Try and minimize them getting in your way, just looping it back underneath so it lies flat against the individual. Okay? Waist high, buckle off to the side, loose tags taken care of.
Last but not least, as caregivers, we need to ensure that residents get the proper rest that they need and that the CBRF is an environment in which they can relax and get the appropriate amount of sleep that they require. Oftentimes, the resident with dementia will have disrupted sleep patterns, or they become agitated, anxious, and unable to relax or rest. In this video, Ginny will tell us how we can help residents relax and get the rest and the sleep that they need.
One of the most basic needs that we as humans have is to feel comfortable and to feel rested. Now, this involves a balance between our need for activity and our need for sleep and rest. We also need to feel, in the sense of comfort, freedom from pain, both emotional as well as physical. Let's first take a look at what is meant by comfort. Comfort could best be described as being at ease, being mentally and physically at ease with not just ourself and our human body, but also our environment around our body. Some of the physical things that can interfere with our comfort include too much activity or not enough activity, temperature extremes such as it's too hot or too cold, either outdoors or in our room or wherever it is we may live. Pain will certainly interfere with one's physical comfort, as will illness or injury to our body. And then in addition, part of being physically uncomfortable is when we lack sleep, when we do not have enough air to breathe, or perhaps enough food to eat. Those will all interfere with our physical comfort. In addition, we need to consider that there are certain things that interfere with our emotional comfort as well. Fear of the unknown, fear of what is going to happen to us. Certainly worry will interfere with being comfortable. Anxiety over what perhaps is going on in our bodies. Person who is ill and does not know what the test results will be probably is very anxious over the results. And certainly we all face stress, but there are times when we face greater stress than others or too much stress at one time. Certainly this will interfere with how comfortable we feel mentally and emotionally. Well, part of feeling comfortable is to feel rested. And this does not mean that that person is to be in bed all day with their eyes closed sleeping. When we talk about rest, let's consider several aspects of what it means to be rested. When a person is resting, we usually refer to this as participating in some activity that results in a feeling of being rejuvenated or renewed or refreshed. We may well be very active in doing something that we enjoy. It may take a lot of physical energy, but as a result we feel like a new person or that we have been renewed in some way. We might do such things as talk with a friend. Perhaps taking a break while you're on the job gives you that 10 minutes away from the stress, just enough to change how you look at yourself in your day. Perhaps reading a book for pleasure, going to a movie, taking a walk. Any exercise you enjoy oftentimes gets your mind into a different state where you're more comfortable with yourself. Certainly taking a vacation is a time away, and that allows you to refresh yourself. Some people take short naps during the day and that refreshes them. Other people use such tactics or devices as meditation in order to refresh or renew themselves. Whatever it is, keep in mind that these are important parts to helping that person feel renewed and rested. Let's take a look at sleep and how important sleep really is to not just your patients, but to you and me as well. And as I go through this, I would like you to evaluate your own sleep situation. What is the quality and quantity of your sleep in your life? Sleep has a very purposeful part. It is a time of renewal, not just physically, but of emotional and mental renewal as well. Sleep is a purposeful loss of consciousness. Now, this is not like a coma. The loss of consciousness during our sleep time can be changed by simply purposefully arousing somebody by calling their name, turning a light on, and they're perhaps close nearby. Also, perhaps such things as pain or discomfort, such as a full bladder, might wake a person up and cause them to get up and take care of that. We know that sleep is a very complex process. Sleep is not just closing your eyes and lying down or sitting up. There is a great deal more to sleep than just that. Sleep involves the brain and various functions that the brain has to control our bodies automatically. And I would caution you that even though it looks like somebody is sleeping, and many times you'll walk down the hall and you'll see everybody with their eyes closed and you say, well, everybody's sleeping. But when you ask the person the next morning how they slept, everybody will give you a different answer. Some will say they slept just fine and well, they really feel refreshed, ready to attack the day. Others will say, I didn't sleep a wink. I had a terrible night. I didn't sleep at all. I feel awful. Believe whatever the person tells you, because the only person who can tell you about the quality of one's sleep is the person who did the sleeping. Remember, we are talking here about not just closed eyeballs. We're not just seeing the eyelids closed, But we are talking here about both the quality of one's sleep while they are asleep, as well as the quantity or amount of sleep that one gets. Sleep is a part of one's 24-hour biological clock. We refer to this as circadian rhythm. Now, we all cycle through this during a 24-hour period. Part of our day, and for the adult, generally anywhere from 5 to 9 hours in that 24-hour period is devoted to this process called sleep. Sleep is also a very basic need that the body has, and it's in the same category of air and food and water. Sleep is vital to our physical function. People who suffer from sleep deprivation certainly will show this in their behavior. They may have hand tremors. Their reflex and response time may be quite slowed. Poor memory, as well as their mind being less alert, may show. Certainly poor judgment, depression, being irritable. There may well be personality changes as well. The person might be either very sleepy, in which case they fall asleep the minute they sit down, or sometimes even standing up, or they may be the opposite. They may be hyperactive and very restless. In addition, we may see physical symptoms such as joint pain or headaches. Various gastrointestinal changes might show up as part of this sleep deprivation. Let's take a look then at what your role is in helping the individual to sleep. We know that you will be very involved in maintaining a sleep routine. You must check the Cardex to find out what is the routine for this individual. What is their normal pattern? Is there a certain time that they prefer to go to sleep? Are there certain things they just must have in order to fall asleep? Make sure that this is a time in the evening when the person is able to wind down. Expect them, if there has been a great deal of excitement, visits, perhaps parties, events, part of the facility, where they're going to be very awake and alert. It may take them a while to go to sleep. Remember, not everybody goes to bed at the same time. Some of your people need to go to bed later, some earlier. And keep in mind that there are certain activities that each of us has to do, and try to maintain that schedule for that patient as much as possible. Another part of your role is to check the environment to make certain that the environment is conducive or ready for sleep for your patients. It's usually customary to just simply close the drapes, to close the blinds or the curtains, to keep out lights or things from the outdoors that might interfere with sleep. We know that the lighting has to be changed. Now, sometimes you will leave very dull or dim lights on. Perhaps there's a nightlight that must be left on. But it's expected that during the nighttime, lights are not bright. Make certain when I talk about lights here that you keep in mind at nighttime, if you work the night shift, you may well walk around with flashlights. Be very careful where you point that flashlight, because if you point it right into somebody's face, you're apt to wake them up. Make certain that the bed is turned down, that the bed is free, smooth wrinkles. Make certain that it is warm enough. Add blankets. Make certain that it has the padding, whatever is required for that individual in order to prepare for bed. The temperature of the room is usually a little bit lower at night, in many places, perhaps in your home, and you add extra warmth by adding blankets. Clear the pathway to the bathroom if the individual is one who must get up during the night. Make certain that there's a safe pathway so that no matter how many times they get up, they are not going to trip and fall. And of course, you want to make certain that side rails are up if required and the call bells are in place. We also want to make certain that the door is usually kept ajar so that noise from the hallway will be somewhat muffled so it doesn't wake the patient. Keep in mind when we talk about environment that noise is a critical part of the environment. And yes, noise does not just happen. It happens because somebody closes a door, somebody walks down the hall, somebody is talking, and you have to be very careful when you are working the night shift to minimize noise. This does keep people awake. Another part of your role is to make sure that the individual has what are called HS cares. HS cares, or bedtime care, is that physical care that we help our clients manage in order to prepare for sleep. Certainly nightwear, nightgowns, pajamas, and some patients choose not to sleep in these, but perhaps in their underwear or other things. There's one young individual that I know who likes to sleep in sweats, sweatpants and a sweatshirt, because she says it keeps her warmer. Make certain the individual has all the fluids or snacks that are required. Now, this is particularly true for the diabetic who requires that snack to be in place to meet insulin needs. Toileting the individual, taking care of oral hygiene, cleaning their dentures is a must part of HS care. And people usually do not sleep with their dentures in. Make certain that eyeglasses are removed, and dentures as well as eyeglasses should both be kept in a safe place and not on top of the bedside stand where they can be knocked off. We also know that part of HS care is washing face and hands and any other part of the body, often the perineal area, especially if the individual is incontinent. Good skin care is vital not just for comfort, but also for good skin condition as well. A back rub is a must if this helps to relax your patient. And many times this is a nice chance to help relax tired muscles that perhaps, even though they have been sitting all day, become fatigued. And of course, part of HS care in addition is making certain that our patients are comfortable in their bed. Several things that you, the assistant, need to consider if you work the night shift. Perhaps you will come on work and find all of your patients asleep. I could wager that would be what you'd like to have, but the reality is many of them will not be asleep, or they will be in and out of sleep throughout the night. Remember again, sleep differs for each one of us. Some of us are better sleepers than others. Some are light sleepers, and any little noise will wake them up. Watch for changes during the nighttime. It is just as important to observe that patient while they're sleeping as when they're awake. Watch for changes in their breathing. Look for changes in skin condition. You can see perspiration, or perhaps you notice when you change the person, they have perspired greatly. Perhaps you notice that they're restless. Perhaps you notice that all of a sudden tonight the bed covers are all torn apart and they've really slept much more restlessly than they normally would. These are important observations to let your nurses know about. Many times this could signal a diabetic reaction or an insulin reaction. Perhaps it's also a response to other medications as well as their illness. No matter what shift you work, whether days, evenings, or nights, whether you're in a nursing home or in the home care area, sleep is vital to healthy functioning. And I would caution you here to be as aware of your own sleep needs as well as you are for your patients.
We will end the personal cares in the CBRF unit with the post-test. Remember that the post-test questions are the same as the pre-test questions. You will not be graded on your responses to these questions. The responses will be reviewed after you have completed the post-test. Turn off the videotape and complete the personal cares in the CBRF post-test in your workbook now. Welcome back. I hope that the test wasn't too difficult. We're going to review the questions now. Number 1, in the CBRF regulations, personal cares are defined as activities of daily living. The answer to that is true.
Number 2, bathing a resident provides a good opportunity for the caregiver to observe and assess the condition of the resident's body. This answer is true.
Number 3, during perineal care, always wash from the clean area to the dirty area. The answer is true.
Number 4, when shaving a resident, it is not necessary to wear disposable gloves. This answer is false. With safety razors, there's always the danger of a cut.
Number 5, a large selection of choices for the dementia resident to select clothing from will make dressing a more enjoyable experience for the resident. This is false. You need to limit the selection to 1 or 2 choices, or it will be too overwhelming for the dementia resident.
Number 6, assisting with elimination and toileting requires prompt action and a special sensitivity on the part of the caregiver. This answer is true.
Number 7, food is identified on the plate of a blind or visually impaired resident using clock, hour hand positions. The answer is true.
Number 8, manipulating objects refers to the skill and performance in handling large and small common objects. That answer is true.
Number 9, always walk on the good or unaffected side of the resident when giving assistance with ambulation. This answer is false. You want to walk on the affected side.
And number 10, dementia may cause a resident to have disruptive patterns of sleep. This answer is true. Sally and I thank you for being with us today. This will conclude the unit on the CBRF training program for personal cares.